Welcome to the lecture of Medical Nutrition Therapy for Renal Diseases. This presentation will focus on the role of the dietitian. It will also review the nutrition prescription for nutrition intervention with chronic kidney disease, acute kidney injury, and kidney transplant. For chronic kidney disease, we will discuss nutrition prescription for the pre-dialysis stages as well as the dialysis stage. And for dialysis, we will look at peritoneal dialysis as well as hemodialysis. 20 million Americans have evidence of kidney disease, and this prevalence is on the rise. Primary causes are hypertension and diabetes, so as the prevalence of these diseases increases, so does the prevalence of kidney disease. This increasing prevalence emphasizes the importance that the renal dietitian plays as part of the medical care team. Regarding nutrition prescription, there are many dietary restrictions for renal patients. This is what contributes to the poor compliance that is very common with this population. Assessment must include a detailed diet history, food preferences, and cooking methods. Understanding how the patient consumes their foods on a daily basis can help to individualize the approach. This is especially important for renal patients. An individualized approach will help to improve compliance. The main part of intervention needs to focus on education and meal planning. Education is very specific because it includes a lot of nutrition knowledge in order to understand how their food intake impacts their quality of life and their disease. Comprehensive education and applications with meal planning and meal planning practice can help to further improve compliance and patient quality of life. In order to understand the specific diet changes, it's important to review the physiologic functions of the kidneys. So I just want to mention their main roles. Maintaining extracellular environment for cell function, the excretion of waste products of metabolism, the maintenance of fluid, electrolyte, and acid-base balance, and the secretion of hormones that modulate hemodynamics. So as kidney function is compromised, we begin to see all of the nutrition problems that arise with fluids, electrolytes, acid-base balance, hormones, hemodynamics, and waste products. First, we'll focus on chronic kidney disease. The definition of this disease is a syndrome in which progressive loss of kidney function occurs. It is not reversible. However, progression can be slowed with appropriate nutrition and medical interventions. It can progress from stage 1 all the way to stage 5, and stage 5 is referred to as the dialysis stage. This is when renal replacement therapy, also referred to as dialysis, or transplant must occur. Stage 1 through 4 are often referred to as the pre-dialysis stage. Every stage of chronic kidney disease requires medication and a specialized diet. The main evaluation of kidney function is the glomerular filtration rate, also referred to as GFR. This rate measures how substances are cleared from the plasma by the glomeruli in the kidney. And it's important with chronic kidney disease staging because the glomerular filtration rate helps to diagnose what stage the patient is in. Briefly, I'll review the pathophysiology of micronutrient alterations that occur during chronic kidney disease. First, we'll address fluids and sodium. The extracellular fluid volume and plasma volume are regulated by sodium and chloride. So as kidney function decreases, sodium retention occurs. This can also lead to edema and then finally leads to hypertension. For potassium, kidneys excrete 80 to 90% of the total daily potassium intake. So as glomerular filtration rate decreases, this can lead to an accumulation of potassium and hyperkalemia. chronic kidney disease inhibits the parathyroid hormone, which I'll refer to as PTH loop. Damaged kidneys can no longer convert the inactive vitamin D to the active calcitriol. This leads to decreased calcium absorption from the intestine, decreased calcium absorption from the kidneys, which results in an overall decreased serum calcium, as well as it increases phosphorus excretion. So this leads to an overall increase in serum phosphorus. The overall goals of medical and nutrition management are to treat the underlying renal pathophysiology in order to delay the progression of the disease. The role of the renal dietitian specifically is to develop a plan for nutrition management, which includes determining the renal diet prescription, then counseling the patient on this prescription that's been prescribed. At follow-ups, it's important to monitor the patient's nutrient intake and compare to the prescription in order to determine compliance and education needs. And then, as I mentioned before, educational activities and ongoing reinforcement is very important to help improve compliance and quality of life for these patients. The medical nutrition therapy during chronic kidney disease is based on the stage of the patient is in. Nutrients are affected at different rates, so different prescriptions are indicated based on stage. For energy, protein, sodium, potassium, calcium, and phos, as well as for specific vitamins, minerals, and fluid requirements. There's also a large focus on comorbid conditions in order to halt the progression of the disease. So in medical nutrition therapy, we'll also often incorporate MNT for diabetes, hypertension, hyperlipidemia, and progression of cardiovascular disease. So before we look at specific nutrient requirements, it's important to calculate the correct weight that you will use to determine your nutrient prescription. For chronic kidney disease, it's important to know the calculation for adjusted edema-free body weight. For an obese patient, we adjust when their actual body weight is greater than 115% of ideal body weight. And for underweight patients, we adjust when their actual body weight is 95% of ideal body weight. The calculation takes their edema-free body weight, so here you want to use their estimated dry weight, and their ideal body weight, and the equation is provided here. So now we'll practice calculating adjusted edema-free body weight. For example, the actual body weight of a patient is 60 kilograms and their ideal body weight is 80 kilograms. So first we have to determine if we're going to use adjusted body weight for this patient. 60 divided by 80 times 100 tells us the percent of ideal body weight. This patient is only 75% of their ideal body weight, so they are underweight and we need to adjust. In order to adjust, we use this equation, and by subtracting edema-free body weight from ideal body weight, we get 20. We multiply that times 0.25, and we get 5, and then 60 plus 5 equals 65 kilograms. So in order to calculate the nutrition prescription for this patient, we will use the adjusted body weight of 65 kilograms. Medical nutrition therapy for pre-dialysis patients. Remember, this is chronic kidney disease stages 1 through 4. First focuses on preventing malnutrition. Protein energy wasting is very common with renal patients, so we must ensure adequate calories of 25 to 35 calories per kilogram per day. Protein intake is moderate. For stages 1 to 2, we use the calculation of 0.8 to 1.4 grams per kilogram per day, and for stages 3 to 4, it's slightly more restricted at 0.6 to 0.8 grams per kilogram per day. And this restriction is to help moderate the kidney damage that can be occurring so that the kidneys are not overwhelmed by excess protein. Pre-dialysis stage also focuses on reducing sodium intake and the DASH diet has been shown to impact progression of the disease for these patients. Chronic kidney disease stage 5 is known as the dialysis stage. First, we'll look at diet prescriptions for hemodialysis patients. Hemodialysis, like all other dialysis modalities, involves removal of blood from the body and circulation across a membrane. This increases the patient's energy expenditure, so they have an increased calorie need of 30 to 35 calories per kilogram per day. They also have higher protein needs because protein is sometimes lost during dialysis, and to match the increased resting energy expenditure, we provide 1.2 grams per kilogram per day. Intakes of the micronutrients sodium, potassium, and phos are controlled in order to prevent excess serum values. If there's greater than a liter of output, then the patient is allowed 2 to 4 grams of sodium per day. But if there's less than a liter of output, or if the patient is anuric, then there's a restriction of 2 grams of sodium per day. Potassium restrictions are 2 to 3 grams per day, and phosphorus restrictions are 0.8 to 1 gram per day. Fluid intake is very important for hemodialysis patients, as it is easy for them to become fluid overloaded. If the patient has greater than 1 liter of output, 2 liters of fluid is recommended. If they have less than a liter of output, 1 to 1.5 liters of fluid is recommended. And if the patient is anuric, they have a 1 liter fluid restriction. Now we will look at a diet prescription for peritoneal dialysis patients. They also have increased resting energy expenditure, so 30 to 35 calories per kilogram per day is adequate to maintain healthy body weight. They have higher protein needs than hemodialysis patients. 1.2 to 1.3 grams per kilo is an adequate goal. And they have more liberalized intakes of sodium, potassium, and fluids. Fluid restriction is not common. It's just important that the patient maintains a balance and does not become dehydrated or edematous. But peritoneal dialysis patients do also have controlled intake of phosphorus, a normal range being 0.8 to 1 grams per day. For both hemodialysis and peritoneal dialysis patients, they have an increased risk for coronary artery disease. Specifically for peritoneal dialysis patients, there's incidence of higher serum cholesterol, higher LDL levels, and higher triglyceride levels. Triglyceride levels are due to the glucose that is contributed from the dialysate, but all of these must be carefully monitored and adjusted in the diet prescription. The therapeutic lifestyle changes diet is recommended for managing patients with chronic kidney disease stage 5. Also, for both hemodialysis and peritoneal dialysis patients, water-soluble vitamin supplementation is recommended because these vitamins are lost during the dialysis process. Also, because patients have increased anorexia and decreased and poor dietary intake. Furthermore, the renal diet is low in fruits, vegetables, whole grains, and dairy. And with decreased renal failure, there's decreased intestinal absorption, as mentioned in the physiology discussion previously. So all of these things put the renal dialysis patient at increased risk for water-soluble vitamin deficiencies. In terms of fat-soluble vitamins, it's important to ensure adequate intake of vitamin D, as vitamin D deficiency is common. In terms of minerals, both hemodialysis and peritoneal dialysis patients have generally elevated levels of magnesium. For this reason, no magnesium supplement is recommended. Iron deficiency is also common. This is closely monitored, and most chronic kidney disease patients require iron supplementation in the dialysis phase. One thing that must be specifically calculated for nutrient intake in peritoneal dialysis patients is the glucose that's provided by the dialysate. Glucose is absorbed from the dialysate and does contribute to the patient's calorie intake. In order to calculate, you must know the daily dialysate dose the patient is receiving, the dialysate concentration, and the grams of dextrose that are provided and absorbed. All of this must be added to the nutrient intake section of your nutrition assessment. So this table is very important in this calculation. It can help you to determine the amount of grams of dextrose that it's provided by different solution concentrations. So we'll work on a problem together. First, you have to determine the grams of dextrose in a dialysate exchange. Remember that the solution concentration is grams per 100 liters. So for example, if you have 1.5 liters of a 2.5% solution, you can calculate the grams of dextrose. So here, we'll divide 2.5 grams by 100 liters, and we get 0.025 grams. We then want to convert this to liters, so we multiply by 1,000 milliliters per liter to get 25 grams per liter. And again, this is grams of dextrose per liter of dialysate. You also must take into consideration the mode of peritoneal dialysis. Glucose absorption rates are different based on continuous ambulatory peritoneal dialysis, which has a rate of 60 to 70% of absorption, and automated peritoneal dialysis, which has 30 to 50% of absorption. So let's work on this problem together from start to finish. If your patient has 4 liters of a 1.5% dialysate solution and 4 liters of a 2.5% dialysate solution that are infused through continuous ambulatory peritoneal dialysis, so remember 60 to 70% absorption, then how much glucose is absorbed? So first we'll calculate the grams of glucose provided by each solution. So 1.5% divided by 100 will give us 0.015 grams per 100 milliliters. We'll multiply by 1,000 milliliters to get 15 grams per liter of this solution. Since there's 4 liters of this 1.5% solution, we'll multiply 15 grams per liter times 4 liters, and that gives us 60 grams of glucose. So now for the second solution, we'll do the same steps. 2.5 divided by 100 gives us 0.025 grams per 100 milliliters, and multiplied by 1,000, this gives us 25 grams per liter of solution. We also have 4 liters of this 2.5% solution, so we'll multiply the 25 grams per liter times 4 liters, and this gives us 100 grams. Sorry, please ignore this grams per liter. This should say 100 grams. And now we'll add the grams of glucose from each solution to get the total glucose. So this is 60 plus 100, which is 160 grams of glucose. We'll convert this to calories from glucose. So 160 grams times 3.4 calories per gram gives us 544 total calories in the dialysate. And because the calories are absorbed 60 to 70%, we multiply 544 times 0.6, and we multiply 544 times 0.7 to get the range of glucose absorbed, which is 326 to 380 calories. And I encourage you to pause this presentation and work through this problem on your own, and check your work with the answers that we got in class to make sure you have this calculation down. So now we'll move on from chronic kidney disease, and we'll look at calculating the nutrition prescription for acute kidney injury. So first, let's look at the definition for AKI. This is an abrupt cessation or decline in GFR that results in failure to maintain fluid, electrolyte, and acid-base balance. This occurs approximately 1% of the time in hospitalized patients, so it's much less prevalent than chronic kidney disease, and it does have a poor prognosis and a high mortality rate. Medical management has the goal to treat the underlying cause of the acute kidney injury. And nutrition therapy depends on the method of dialysis. Some patients with acute kidney injury are placed on hemodialysis. For those patients, you can refer to calculating the nutrition prescription from the previous section. Some are also placed on peritoneal dialysis, and you can focus on the nutrition prescription from the previous section. But a common dialysis modality for acute kidney injury is continuous renal replacement therapy. And this is a 24-hour continuous dialysis. For these patients, restriction of protein should not be a component of care. Protein needs are actually much higher during this time, and standard formulas are used for enteral nutrition support. For this recommendation, I encourage you to read the Aspen Critical Care Guidelines, published recently in 2015, because this recommendation to use standard formulas rather than renal-specific formulas is a newer recommendation based on current research. So when you're writing your diet prescription for a patient on CRRT with acute kidney injury, you want to remember that they have increased needs and high protein intake. Because of the 24-hour per day dialysis, their resting energy expenditure is much higher, and they're often in the critical care setting, so you can use these predictive equations or indirect calorimetry as is applicable. Standard protein recommendations are 1 to 1.5 grams per kilogram per day. If your patient is also in a hypercatabolic state, their protein can increase from 1.5 to 2 grams per kilogram per day, and the max dose for CRRT patients in catabolism is 2.5 grams per kilogram per day. Sodium, potassium, and phos do not have specific recommendations, but losses are replaced on a daily basis in order to maintain serum levels within normal limits. I really like this table from your book, and in order to succeed on your self-assessments and in the following case studies that we'll practice, I encourage you to study this table and understand the different recommendations for each stage of chronic kidney disease, for hemodialysis, peritoneal dialysis, as well as acute kidney injury. And now we'll look at post-transplant diet recommendations. Nutrition therapy differs for two phases: the acute phase, which is up to 8 weeks after the transplant, and then the chronic phase, which is 9 weeks after the transplant. There's much less specific recommendations, especially on the micronutrients, than in chronic kidney disease and acute kidney injury. But what I want to call your attention to is the increased protein needs during the acute phase after transplant. Additionally, energy needs are higher post-transplant, but then in the chronic phase, the patient should have standard energy requirements to maintain a healthy weight. The other thing I'd like to call attention to are the micronutrient recommendations in the acute phase, which are more restrictive than the chronic phase. For patients post-transplant, we are looking at healthy diet recommendations. For carbohydrates, glucose intolerance is common, so we focus on emphasizing dietary fiber and complex carbohydrates. A low-fat diet is recommended, as well as sodium monitoring. Hypertension is common, so the DASH diet and the TLC diet are both good approaches for this population. And this concludes the lecture for calculating nutrition prescriptions for renal patients.